interferon in treating neuroendocrine tumors. Thank you.
Thank you, Ed, for this kind introduction. I think everyone is rather tired now, so we had to be short. This is Uppsala in the spring. So interferon actually was the if drug for cancer when it was developed in the early 1980s. But today, if you look at solid tumors, it's only 3 tumors that are left that respond to alpha interferon. And that is mid-gut carcinoids, and it's kidney cancer and malignant melanoma. But if you look at this cartoon, Flash Gordon, he was already using interferon in 1960. So it's a very old drug. Why did we actually look into treatment with alpha interferon? The reason was that we noticed quite early that these slow-growing tumors were not responding to cytotoxic agents. And we tried to look into what is the problem with these tumors, what about the immunology in these tumors. And we noticed quite early on that the natural killer cell function was depressed in carcinoid tumors. And the only agent in the early 1980s was alpha interferon to stimulate the natural killer cell function. So that was the reason, and this is one of our early papers. This is our first trial with alpha interferon in carcinoid tumors, where we could clearly demonstrate that we had an effect on both tumor growth and hormone production. This was a small trial, but I'm going to show you that this compound is now registered in Europe in most countries. This guy, this is from a Swedish magazine. He is telling us that he has been treated with alpha interferon for 22 years. And he's still living, I can promise you. I saw him just a couple of weeks ago. And when he first was diagnosed with a carcinoid, they told him that he has only 2 years left to live. It's very important when you are working with interferon that you titrate the dose individually in each patient. That means that a small person might have a very low dose of interferon, whereas a big person need more interferon. We have started to use more and more long-acting interferon, pegylated alpha interferon, 75 to 150 micrograms per week. And we know today that the pegylated alpha interferon is working as good as the immediate release alpha interferon, and the side effects are somewhat lower with the pegylated form. We have a neuroendocrine tumor, and these tumors are regulated by a lot of growth factors, and they are hypervascular. And what is the role of interferon? We have different types of interferons. They are called cytokines. We have alpha interferons, usually produced by leukocytes and lymphoblasts. We have interferon beta, usually produced by fibroblasts, and gamma interferon by T lymphocytes. And all these interferons are in your body at the moment. So you have circulating levels of these compounds, cytokines, regulate a lot of different functions. We have been trying all these types of interferons in the treatment, but today alpha interferon is the most useful one. We have looked into the mechanism of action because we were quite interested to see what effect does this compound have. And as you can see, there is a lot of signal transduction pathways. I will go through them, but a lot of intercellular enzymes are activated, which result in the stimulation of the immune system and natural killer cell activity, as I started with. We have also an anti-angiogenic effect, so it stops the blood supply to the tumor. It inhibits the VEGF production and other angiogenic factors. And it also stimulates apoptosis, programmed cell death. So it has a lot of actions and, of course, also some side effects with that. Just to show you the effect on blood supply to the tumor, these are a study we did together with a group in Berlin. And we looked at VEGF and newly formed blood vessels in neuroendocrine tumors. And these are two specimens taken before and after 6 months of treatment with alpha interferon. And this is staining for newly formed blood vessels, and you can see a significant decrease in parallel with a decrease in circulating VEGF levels. There are a lot of studies on alpha interferon, and of course you can't read this table, so therefore I will concentrate it to 27 studies that have been published. This was until 2006. More than 600 patients, and the interferon dose, you can see, is about 3 to 5 million units 3 times per week. And they have been treated in median up to 39 weeks. Symptomatic response, improvement of carcinoid symptoms in 62%, biochemical response in 50%, and then we have the tumor responses, which have been discussed by Dr. Kocha, and we have regression 10%. That is the WHO criteria. If we go for RECIST criteria with a 25 to 30% response, it's higher, 20-25%. Stabilization, 65%, and we just discussed that stabilization is a response in this type of treatment. We tried to combine interferon with cytotoxic agents. These are 2 studies from our group, and we couldn't see any advantage of combining it with cytotoxic agents. So you didn't get more responses, and you have significant adverse reactions. There are several studies on combination with somatostatin analogs, and unfortunately the randomized trial, there are 3 randomized trials, couldn't clearly demonstrate an advantage of combining alpha interferon with somatostatin analogs, and there were several reasons for this. This study from Germany, they lumped together different kinds of neuroendocrine tumors, foregut, midgut, hindgut tumors, and therefore it was not so easy to sort out the results. And this is a Swedish study, and that also was a problem because we intended to include 120 patients and only 66 was included. But you can see that the risk of tumor progression is significantly better for the combination. But the 5-year survival rate is quite equal. But you can see that 56% versus 36%. If we had included more patients, I think it had been significant statistically. And this is a German randomized trial, again, lumping together different types of neuroendocrine tumors. What can be said is that the combination of lanreotide plus alpha interferon had a significantly better effect on symptoms. This is a patient that participated in the new trial with pasireotide, and you heard about the good effect of pasireotide on controlling clinical symptoms in terms of flushing and diarrhea. And this patient had a dramatic effect in terms of symptom control. But the problem was that she continued to grow in the tumor. So the symptoms disappeared, but the tumor was growing, and also the chromogranin A levels, as you can see. So what I did was, in this, after 11 months, I took her out of the trial and combined some 230, this pasireotide, with alpha interferon, and you can see the dramatic response in chromogranin A, as well as tumor size reduction by 70% already within 3 months' time. And this patient is still responding 2 years later with this. So this is something for the future when pasireotide become more available. Combination with alpha interferon might be of interest. The adverse effects are significant. Of course, there's an active drug, and of course, you can then also expect to see some adverse effects. And I think the most severe one is the chronic fatigue syndrome that occurs in 30 to 70% of the patients, usually grade 1 or grade 2, but some patients also get mental depression, weight loss, anemia, and so on. And there are contraindications. You should not give it to patients with autoimmune hepatitis, psoriasis, systemic lupus erythematosus, rheumatoid arthritis, because you can get a flare-up of this autoimmune disease. And actually, some of these patients develop autoimmune disease during interferon treatment. I have at least 4 patients that developed SLE syndrome, and the good thing with development of SLE syndrome was that they cured the disease. This is the only patient with metastatic disease that cured themselves. And the reason for this is that they developed autoantibodies against the tumor. So during this SLE syndrome, they developed autoantibodies against the carcinoid tumor cells, and they attacked the tumor cells and killed it. And we are quite sure that they were cured from the disease, because one of them was operated for gallstones, and we could look into the abdomen. She had multiple liver and lymph node metastases, and nothing was seen afterwards. So, but of course, that is not a good thing to develop an autoimmune disease. But it's indicating that the immune system can be activated by this drug. We have seen this slide before. What I want to point out is that the response rates for chemotherapy in carcinoid tumors is not better than for alpha interferon. And you have seen these new drugs that are around at the moment, and both tyrosine kinase inhibitors and also anti-angiogenic substances of different type. And what I want to point out is that the response rates is about partial remissions, 9 to 10%, similar to alpha interferon. So it's not more effective than alpha interferon. And you have adverse reactions, of course, also with these drugs. And you have seen these waterfall plots. I just wanted to show you that this is a new way of demonstrating that you have effects, although not reaching RECIST criteria with 30% reduction of the tumor. This is with Sutent. It's interesting to notice that Sutent, this tyrosine kinase inhibitor, is not as effective in carcinoid tumor as in pancreatic tumors. And again, you see the waterfall plot, and you see that the responses are significantly better in the pancreatic tumor compared to the carcinoids. So, at least in Europe, interferon is a medical treatment for low proliferating neuroendocrine tumors. It's registered in almost all European countries on that indication. It is also second-line treatment after cytotoxic treatment. If you have an effect of the cytotoxic treatment but cannot continue with it, we usually add alpha interferon afterwards. I am a strong believer that you have a benefit of the combination of somatostatin analogs and alpha interferon. And although the 3 randomized trial couldn't clearly demonstrate it due to different problems, I think from the clinical praxis it's quite clear that it's an advantage to combine these 2 drugs, and you also reduce the side effects of alpha interferon. So this I showed you this morning, and you heard that median survival doesn't mean anything, but for me it's a quite difference between a median survival of 115 months versus 33 months. Of course, it's sometimes difficult to compare the patient material, but these are patients with metastatic midgut carcinoma tumors, and you could see that from Dr. Paseka's presentation that they had a similar 5-year survival rate, 74, and we have 77%. So, and they are using the same type of multidisciplinary approach, combining active surgery with different drugs when you have a progression. And I'm sorry to say that this is standard of care in US at the moment, not at specialized centers. For the future, I think we should look into a combination of alpha interferon with new agents. And I pointed out that I'm very interested in alpha interferon plus pasireotide. I think that is an area which we can maybe see more significant tumor reductions. There is a study now ongoing in US, alpha interferon plus Avastin. And of course you can combine also with other substances. So does interferon still play a role? You have all these new drugs. From my point of view, the answer is yes. And the new IBs and MABs, you have a lot of IBs and MABs around. They have not presented better response rates. The cost for alpha interferon is less than 1/10 of the new agents. And the side effects are not more severe than for the new drugs. So what should we do in the future? Because if we want to use alpha interferon, and we have some ideas at our center. What we just now are doing is that we are developing a plasmid. A plasmid is an organelle that you can introduce genetic material into this, and you can get a production of or a stimulation of a gene starting a production of a protein. And what we have managed is to put the alpha interferon and beta interferon gene into such a plasmid and start production of high concentration of alpha interferon and beta interferon. And this is some of the in vitro and in vivo data showing that you have production of alpha interferon by this plasmid, and you have also an anti-angiogenic effect when you look at it, and you have also reduction of blood supplies and your inhibition of tumor cell growth. And what are we doing with this plasmid? Of course, if you inject it just in the bloodstream, you get the same side effects as if you give the real alpha interferon. So what we are doing now, we put these plasmids into nanoparticles. These nanoparticles, very small nanoparticles. And we are working on nanotubes, which is carbon nanotubes, or we are using nanodiscs, which are lipids. And we put this plasmid into this. We coat the nanoparticle with antibodies to somatostatin receptor type 2. And what do we get then? A magic bullet that goes directly to the tumor, and it's taken up by the tumor cell. And so this is a gene delivery with this nanoparticles, and they are taking up of the tumor cells. And of course it will take time to develop this into treatment in patients, but it's a quite interesting concept, and it's a way to reduce the side effects. So that is a look into the crystal ball, and thank you for your attention.